Think forward. Think Research Channel.
Add my word of welcome and express my pleasure in introducing to you a friend of mine. Professor Elizabeth Johnston Taylor is a registered nurse who earned a Ph.D. degree from the University of Pennsylvania in 1992. She also did postdoctoral work at the University of California at Los Angeles in the School of Nursing. Her experience as an oncology nurse made her interested in the way people relate spirituality to their health and their illness. And she specialized in that field for some time now. In addition to her work in nursing, she's taken clinical pastoral education, or CPE as you may know it, which is the way hospital chaplains become trained for their work, and some pastors do as well. Dr. Johnston Taylor has had research funded by the National Cancer Institute of the NIH. And she has also been funded by the John Templeton Foundation for work that I think she's currently working on. Also by the Oncology Nursing Society and by the Hospice Nurses Association. So she's been a well-funded researcher. And this has led to many publications, and her well-received book, published by Prentice Hall, which is titled Spiritual Care, Nursing Theory, Research, and Practice. She's given of herself to the community. She's a member of the Oncology Nursing Forum and the Holistic Nursing Practice Editorial Board. I know about her editorial work for that journal since she talked me out of an article for it. And she has been a collateral reviewer for Sigma Theta Tau. She's the president of the Iota Lambda chapter of Sigma Theta Tau, which is the Nursing Honor Society. Beth loves her scholarly activity, but she told me she has to leave. I can't even take her to lunch because she has to get back to being a mommy. She has two beautiful, incredibly bright daughters, Catherine and Alyssa, and she's married to a professional musician, one of the best, Lyndon Taylor, who plays violin for the Los Angeles Philharmonic Orchestra. We're looking forward to Beth's presentation today, Should Clinicians Dabble in Patient Spiritual Angst? Since I'm an ethicist, I'm looking for the ethical implications of that talk. Would you welcome Professor Beth Johnston Taylor to this podium?
While we find the presentation, I just want to say thank you very much, Jerry, for your wonderful introduction. And I'd also like to give credit where credit needs to be placed. The whole title for this presentation is actually Mark Carr's idea, and I was actually very happy to be so challenged and enjoyed looking at the literature to put this presentation together for today. I also want to give credit to the Templeton Foundation because they've actually been generously paying my bills the last almost 2 years, and they are the ones that have allowed me to do the thinking that you're seeing today. They are also, let me just tell you quickly about the study I've been doing with their money. Out of my own personal experience, I've always, thank you, Don, always asked the question, even after the training Jerry alluded to, many times I was left wondering after I encountered a patient, boy, what should I have said? What would have been better? I don't think I really did it quite the way it could have been. So the funding allowed me to put together a curriculum, basically, a workbook and supplemental DVD that trains healthcare professionals about how to talk ethically and effectively with their clients. And we're just in the final throes of bringing back in the last of the 200 surveys, pre and post tests that were done with this, and we'll be starting to crunch the numbers and writing it up very soon. Okay, let's begin. To whet our appetite for the topic, I'd like to present a few scenarios, many of them actually from my own experience or those of persons I know. Here's one. There's an atheist, dying man in an intensive care unit with pancreatic CA. His RN angers him with her frequent offers to introduce Jesus to him so that he can be saved. Should clinicians dabble in patient spiritual angst? A conservative Christian is annoyed and loses respect for her nurse who offers to perform therapeutic touch or Reiki. Therapeutic touch and Reiki for many conservative Christians, they would say that was a monistic or non-theistic approach, and it was incongruent with their theistic worldview. Consider a middle-aged Jewish woman with post-surgical complications who says, "I'm really discouraged. If it's okay, nurse, do you think you could pray with me?" It's really happened in New York City. And the nurse responded, "I don't do that." Left this patient very saddened and very discomforted. Imagine a skilled nursing facility resident who complains while being bathed. "I hate to be such a burden. I wish the stroke had taken me." To which the LVN might respond, "Okay, let's get you under the shower now. That'll feel good." Totally bypasses the spiritual angst of this patient. Here's another one. A 43-year-old woman with as yet untreated curable breast cancer states, "Thanks, but no thanks, doc. I'm going to let God perform a miracle. I'll see you later." Should the doc say anything that addresses her spirituality? The patient seemed to have, this is actually from real data I collected about a dozen years ago where I asked nurses to relate an experience of providing spiritual care. Here's a nurse who wrote me, "The patient seemed to have unspoken needs. I asked questions to assess the needs. Then I made suggestions like praying, mentioning my past painful experiences, the ones she had had, and how God had met my needs, discussed different possibilities, and made other suggestions, if one was not a helpful one." So in other words, she kept throwing things at the patient, hoping one would stick. A final illustration. Another nurse who wrote for this study a dozen years ago. "My patient was in the end stages of his cancer. His vital signs were awful. He was mottled. His level of consciousness was fluctuating. He was very restless and anxious as soon as he appeared to be restful. He would pop his eyes open and again begin to struggle. His wife and I assured him of our love and support. I asked him if he was afraid to die, and he answered affirmatively. I asked him what his religion was. His wife responded for him, stating he was Protestant. I then reviewed Christian belief in afterlife with him and provided the video Life After Life by Dr. Moody. The patient became calm and died shortly afterwards." You may be saying to me, now Beth, give us a good example of spiritual inquiry or spiritual care. I don't like any of these. Well, I'm going to move on. I wanted to whet your appetite. And I'd like to also just acknowledge up front here that I think we as healthcare professionals really are in a privileged position when we're at the bedside. We do not have the pre-established roles for relating that these patients do with their clergy, with their family, with their friends. There is actually, I think, sometimes some virtue in being a stranger. We don't have the white clerical collar. We don't have the baggage of being a member of the clergy or even being a chaplain. Sometimes we're the one who is most literally present with patients when they are in extreme situations, when they are most yearning for spiritual comfort. We are in a privileged position. Okay, having brought this to the surface, though, I'd like to unravel what some of the questions might be inherent in asking the question of, should clinicians dabble in patient spiritual angst? Well, as I sit in my armchair or in front of the computer, I say, okay, well, should healthcare professionals dabble? Now, what does dabble mean? To me, it means, anyway, approaching without much training, perhaps approaching in a superficial way, spiritual angst. Well, if that is what's meant, and if we say, well, no, we shouldn't do that, then the question arises, well, is it okay, though, if we are trained? And if that's okay, well, then what training would qualify us to dabble? Do we need to test for spiritual care competency? Or might we place the emphasis somewhere else and say, well, should healthcare professionals dabble in patient spiritual angst? You might say, well, no, not with angst. Then the question, at least for me, comes, well, how about minor spiritual concerns? Should we do that? And at what point, then, does the healthcare professional bow out? There's a continuum between minor concern versus angst. Well, I went to the literature and was impressed. There were a handful of articles that were very informative. And the first one I'd like to present you with is one by an ethicist at the Hastings Center, Nancy Berlinger. And in her article, she raises some additional questions that I think are related to this topic. She asks, should healthcare well, she's actually talking about physicians, but I want to generalize it. Should healthcare professionals condemn spiritual beliefs and practices that they believe are unhealthful? In other words, does respecting autonomy of a patient mean supporting whatever they think provides ultimate meaning, even if you think that could be dangerous? Ought healthcare professionals to promote spiritual practices and beliefs that they believe are unhealthful? Or would this be coercion? How can healthcare professionals recognize their own personal assumptions about spirituality so that they do not constrain care? So in other words, if a healthcare professional sees spirituality as religion, then they're going to project that onto the patient care encounters they have. And they may be unable to see spirituality that's manifest for someone who isn't religious. And of course, the converse could be true. Does conceptualizing medicine as a spiritual practice, which is being done, there's Rachel, or no, what's her name? Blanking on it. Rachel Remen. There we go. And she's developed this curriculum for physicians looking at the art of healing. And it raised the question for some if this conceptualizing medicine as a spiritual practice actually runs the risk of sacralizing the physician's role and increasing the physician-patient power imbalance. One person she quoted actually raised the question, in the past physicians have had to deal with the demon of arrogance. Might in the future they have to deal with the demon of piety? Well, there is a nurse up in British Columbia who is actually going to visit us in a month, Barbara Pissett, and she's written very thoughtfully on the topic of spiritual care and its appropriateness within the practice of nursing. And what she does is explore the assumptions that when we as nurses and as other healthcare professionals have been talking about this notion of spiritual care and talking with patients about their spirituality, we do so fairly glibly, not recognizing that there are some fundamental assumptions that need to be explored further. And she brings some of these to the surface, and I'd like to share a couple of them with you. The healthcare professional has spiritual expertise is an assumption we're making when we write books about spiritual care. We have an assumption that we as healthcare professionals can make a judgment regarding a patient's spiritual condition. And if we make a judgment, that assumes that there must perhaps be some normative frame against which to judge a person's spirituality. So it raises the question, is there a norm? Or is it subjective? Is it whatever the patient thinks it is? If there is a norm, is it universal, or might the healthcare professional and the patient disagree about what it is? Another assumption is that healthcare professionals can influence the patient's spirit towards some desirable outcome. Can healthcare professionals affect spiritual outcomes of patients? When might it become coercion? How can a healthcare professional know that they have judged correctly? She writes something that just hit me between the eyes here. She says, imagine yourself newly diagnosed with cancer and you're on an acute care oncology unit. Would you desire your nurse, a relative stranger, to perform a complete spiritual assessment on you and to formulate a plan of care that would entail intervening in your life towards some predefined spiritual end? Would you? Put it that way, I'm not sure I do. Well, let's frame the context for which we're asking this question. And here we are at Loma University. It's a Seventh-day Adventist educational institution. Its former name was College of Medical Evangelists. When you look at Ellen G. White's comments about what the foundation of this work we do here should be, she talks about, this is a woman who wrote over 100 years ago, and in her language of that century, she wrote about how medical missionary work is the right hand of the gospel, an entering wedge, and a way the gospel is to be practiced. In contrast, think about the society we live in now. One way we could very simplistically describe it, perhaps, would be to say that there is a progressive secularism, and then on the other extreme might be right-wing religion. And I can't help but wonder if this question we're asking this afternoon in a context of healthcare is really a microcosmic look at something that's going on at the macrocosmic level. Okay, so let's look at the context here. What have we as healthcare professionals been writing and thinking about this business of talking with patients about their spiritual angst? Well, if you review the literature on this topic, you will see that there are those who come out in favor and there are those who come out against. To summarize the arguments, those who are in favor would say, hey, we've got this burgeoning volume of empirical research. We've got literally now hundreds of studies, and you've heard them cited here in other presentations at Loma Linda. But they link spirituality and religious well-being with physical well-being and emotional well-being. There's some sort of association or linkage between these factors. Also, there's a lot of research out there documenting that Americans, I'm sure other people in the world as well, you could say, find that spirituality and religiousness provides mechanism for coping or provides avenues for coping. Religious practices like prayer and reading scripture that's comforting are coping strategies. Then now, in America, as well as the UK and other places, there are actually mandates for us as healthcare professionals to include spiritual assessment and support of spiritual practices as they pertain to health. I mean, think of the JCO mandate. That's the biggest one that comes to mind. But there are also professional mandates in codes of ethics, in curriculum prescriptions, at least in nursing in the UK, that say, yeah, you've got to teach your students about spiritual assessment and support. And there's an increasing volume of research that documents that there is consumer interest and desire for healthcare professionals to address their spiritual well-being. And then lastly, what hasn't gotten much attention, but I think probably all of you in this room can understand. I think perhaps one reason why there's an increased interest in this whole topic is because as technology has increased, the soft touch of caring, the art of caring, seems to have taken a back seat. And what really gives us warm fuzzies about our work, what really provides professional job satisfaction, is oftentimes when we can address that spiritual dimension. So, I think in order to keep the soul of the healthcare professional alive, perhaps they need to be allowed to address, shall we say, the soul of their patient, and because that involves addressing their own soul. Well, on the opposite side, you will find those who respond by saying, all that research you're citing, it's actually not that strong, it's not that generalizable, the jury's still out. Don't jump on this bandwagon yet. And it's not the healthcare professional's role. We're crossing boundaries. This is something we should keep sacred for the clergy, the chaplain, the spiritual care expert. Besides, we really don't receive adequate training, and since we don't, this leaves it, makes us incompetent as spiritual caregivers. Also, there's this high risk for coercion, proselytization, or psychospiritual abuse even. So, no, we shouldn't do it. And besides, we don't have time. What I'd like to do in the next 3 slides is give you little quotes or blurbs from the summary sections of 3 articles. If you were to write a paper on this topic for me, I would not give you an A unless you cited at least these 3 articles, because they're pivotal in the discussion when you look at the literature. This whole question actually came to the forefront not until, I would say, 1999, when Richard Sloan and company, his friends, wrote these articles that challenged this idea of providing spiritual care, healthcare professionals doing it. So let me quote the end of one of his articles. Between the extremes of rejecting the idea that religion and faith can bring comfort to some people coping with illness and endorsing the view that physicians should actively promote religious activity among patients lies a vast uncharted territory in which guidelines for appropriate behavior are needed urgently. No one can object to respectful support for patients who draw upon religious faith in times of illness. They were willing to accede that. Then Walter Larimore, who is a physician, and I noticed on one of his articles the byline was a focus on the family, so you got the idea of where he's coming from. In his article, he wrote, "The evidence to date tells us that it is actually clear that clinicians should encourage positive spirituality with their patients. Until more evidence is available, we should encourage healthcare professionals to assess their patients' spiritual health and to provide indicated and desired spiritual intervention." So clearly, these guys are on opposite sides of the table. Now, Post, Polchaski, and Larson, they wrote kind of in the middle of these two, and they're basically very positive, but acknowledge a need for caution. They wrote, "Patient expressions of spirituality should be screened for and respected by physicians." I mean, Polchaski's big on assessment, right? She's got this FICA acronym for it. "As the healthcare market presses provider in a more holistic direction that includes attentiveness to patient spirituality, we expect that the ethical issues that we are beginning to address here will become even more significant in the standard clinical setting." Okay, so you've been exposed now to what the question entails. What are some of the ethical issues in it? So now let's start moving towards an answer. And of course, I'm not, foolish or wise enough to say I've got the answer. So let me share with you some ideas that might help us move towards one more closely. Wonderful article that really resonated for me was one by physicians Curlin and Hall. Hall also has an MDiv, and they wrote a year ago about how really these guys, that I've just been sharing with you really are asking the wrong questions. They're really kind of coming from the wrong paradigm as far as they're concerned. And Curlin and Hall actually suggest we really need to reframe what's going on here. Instead of talking about how the healthcare professional is a stranger to the patient and how they need to perform the techniques of spiritual assessment and the interventions of involved in spiritual care, we really instead need to talk about the ethic of friendship. And for them, they would talk about this moral or ethic of friendship as acting towards the patient out of a desire for the patient's good. So how do the questions get asked and answered, perhaps, between these two paradigms? Well, the folks I was just discussing with you were asking the question, are healthcare professionals competent? Instead, Curlin and Hall would say, instead of competence, we need to talk about how we can be wise, we can have wisdom. And the question instead should look like, how can healthcare professionals wisely navigate discourse? Instead of asking the question, does dialogue threaten autonomy? Perhaps we should instead be talking about candor. How might healthcare professionals clarify and promote patients' flourishing while showing deep respect? And instead of asking, how can healthcare professionals maintain neutrality while talking with patients about their spirituality and religiousness? Instead, they would say, we need to be asking, how should differences regarding spirituality and religiosity be respectfully negotiated? Feels very different, doesn't it? And actually, Pasut, along with her colleague Rick Sawatsky, have a definition for spiritual nursing care that I think is congruent with Curlin and Hall's framework. And I'd like to share it with you because I think even physicians and other non-nurses can benefit from this. They describe spiritual nursing care as an intuitive, interpersonal, altruistic, and integrative expression that is contingent on the nurse's awareness of the transcendent dimension of life, but that reflects the patient's reality. This is really key for them, the patient's reality. We are not deciding what it should be or what it is even. At its foundational level, spiritual nursing care is an expression of self. As Bradshaw suggested, it is the very way of love lived out in the relationship of care. Spiritual nursing care begins from a perspective of being with the patient in love and dialogue, but may emerge into therapeutically oriented interventions that take direction from the patient's religious or spiritual reality. When I read this and think of Hall and Curlin, I thought maybe those of you who are from Loma Linda and would appreciate this quote. I think it really supports what one of the pivotal influence, mover and shaker for Loma Linda in its early beginnings, Ellen G. White, wrote in her book she called The Ministry of Healing. Christ's method alone will give true success in reaching the people. The Savior mingled with men as one who desired their good. Sound like Curlin and Hall? He showed his sympathy. I put sick in there because if you look at the literature now, we would say, it's not sympathy. That's really the professional goal here. It's empathy or compassion. Anyway, he showed his sympathy for them, ministered to their needs, and won their confidence. Then Jesus bade them, follow me. Well, I'd like to share with you just a little sprinkling of some of the empirical research that feeds our question or our desire for an answer to our question. And what I'd like to do is share with you the research that looks at the healthcare professional patient spiritual care relationship or inquiry, discourse, whatever language you want to use here. So we'll look at some research that comes from medicine, from nursing, and then some that actually asks patients what their perspective is. I'll start with, and let me tell you, medicine's got a lot more research on this topic than does nursing or any other healthcare discipline that I am aware of the literature on. This first slide shares with you 3 studies, and they all are of general practitioners or family practice physicians. And the first 2, Illinois, Missouri, you're looking at the Midwest. The last one comes from the West Coast. But look at them. Across all these studies, you've got roughly 60 to 70% of the physicians reporting that they do think they should address their patient's spirituality, or they should be aware of their patient's spirituality. However the question was asked, something to that effect. Of course, every study asked it differently. Another study looked at primary care physicians in the Midwest, and another one looked at residents as well. And even with residents, you'll see, again, a good number of them saying, yes, we think this is important in our care, overall care. The study that I would say is the most credible or the most helpful is one that came out just this year. It was a randomized, stratified sample of physicians in the U.S., sent it out to 2,000. 1,260 responded, which is an incredible response rate, I think. And look, 91% of them said they thought it was appropriate to discuss religious or spiritual issues if the patient brought it up. 45% it is usually or always inappropriate to ask patients about their spirituality or religiousness. 43% thought it was inappropriate to talk about their own beliefs or experiences, even if the patient asked. Or they thought it was okay if the patient asked, but 17% said it would never be appropriate. These physicians, when they looked at some of the demographic variables, they found that the likelihood of a physician addressing the patient's spirituality or asking about it was directly related to whether or not that patient was personally very religious. And that's true actually in the nursing literature as well, and actually in the literature from patient perspectives. Okay, I did one study, a couple studies actually, with fairly large samples where I asked nurses what their perspective was about providing spiritual care. And again, if you were to just really, for me to give you a quick and dirty idea of what nurses think, or at least these oncology and hospice nurses. If you were to put positive attitude towards providing spiritual care on a scale of 1 to 5, with 5 being, the most positive, they came out around 4. So pretty positive attitude. Likewise, pretty strong correlation, 0.43 to 0.5, between their attitude towards spiritual care and their comfortability and frequency of providing spiritual care. And again, their own self-reported spirituality was the main variable that explained their positive attitude towards providing spiritual care. Pushing on, patient perspectives, maybe the most important piece to look at. To just summarize, and there's about 20 studies that give us data here. Most patients want and value a physician's spiritual inquiry. And like I said, most of these studies were done to inquire about the perspective of a physician doing this. When you ask, I did a study where I asked them about whether they wanted a nurse to provide spiritual care for them. I can't compare, but my gut is maybe they want nurses a little less than physicians, which is, of course, very distressing to me. But anyway, most patients do want and value physicians' spiritual inquiry, especially if, here's the data, if they are having a serious or life-threatening diagnosis or dying, or if they have a good relationship with the physician established, and like I said, if they are religious. Let me say up front, yes, physicians and nurses are not seen as primary spiritual caregivers, and the little data I have for this would actually show it's not even clergy and chaplains, it's family and friends. This one study I did actually collected most of my data here at Loma Linda. I thought you might be interested in seeing documents if you were to ask a patient or family caregiver what they needed to see in their nurse before that nurse was to provide spiritual care. What comes out at the top? Relationship. Okay. I have about 3 minutes to share with you the clinical implications I see from this thinking and this empirical evidence. I'd like to let you know that someone who I cite an awful lot is Jerry and Betty Winslow. They've got this wonderful article, and I hear you've got another one coming out where they provide ethical guidelines for the provision of spiritual care. And they're most appropriate as we ask our question about spiritual angst and whether we should dabble in it. But as I thought about what I was reading the last couple days, the implications that popped to the top the most for me, of course we could make many, but they were this issue of assessment. You know, we've got a lot, and I've summarized them in book chapters. We've got a lot of literature that tells us about how we healthcare professionals can give some very in-depth spiritual assessments. But I'm now starting to think that may be inappropriate for us as spiritual care generalists, shall we say, not specialists. And it really reinforces what I've been arguing for the last few years, and that is we really should follow a two-tiered plan towards assessment rather than doing some huge onslaught of a spiritual assessment. The two-tier plan being initially do a very brief screening, i.e. ask them, hey, you don't say, hey, but you say, how do your spiritual beliefs and practices affect you now as you relate to your illness or your health challenge? And then secondly, how can we as your healthcare team support your spiritual health, or something to that effect? Likewise, perhaps we shouldn't be scratching where it doesn't itch. We need to approach patients with mutuality. Data shows that, so does the philosophical inquiry I've shared with you. We've got to remember we are on a journey with these people. We are no more powerful than they are. We are no more intelligent than they are about spirituality. We are no more advanced along some spiritual maturation scale. We are co-journers with them. And I think if we can keep that attitude, that is what is essential when it comes to providing ethical spiritual care. We are not the savior. Healthcare professionals must be competent and or wise. I'm not quite sure exactly the ultimatum to make here, but I am struck by Barb Pisut's comment. It's not enough to claim that we have an ethical responsibility to provide spiritual care and then consider competence post hoc. Okay, I was going to share with you just a little information that I thought might be helpful for those of you who are clinicians who might be saying, okay, well, how should I do it? When, for example, a patient asks, what do you believe? Well, how do I respond without being coercive? And so let me just say that there are principles you can get in mental health textbooks about how to do self-disclosure that I think easily apply to us when we're talking about spiritual inquiry and assessment or disclosure. I'd also like to remind you that the helping literature, the counseling psychology literature also reminds us there are ways that people talk to us and share their spiritual angst with us, and we are so discomforted ourselves by it that we run away. And so I'd like to remind you that if you can, to try to not run away, recognize the ways that you do, and then hold those in check. Dr. Lowe likewise presents pitfalls about talking with patients regarding their spiritual and religious issues, and he highlights how oftentimes we're trying to solve the patient's problems, we're trying to resolve their unanswerable questions, we go beyond our expertise and role, we impose our personal beliefs sometimes, and provide premature reassurances inappropriately. So we don't want to do that. You may be saying, okay, I'm not the expert you're telling me, so when do I make a referral, though? And I just give you a simple answer. When you don't have time, you don't have knowledge or ability. There may be a complex theological question the patient is bringing to the surface. Get the appropriate person for that. They may be exhibiting symptoms of an unhealthful or harmful religiousness. Again, get an expert. Okay, so since I know we want to allow some time for questions, what's that? 4 or 5 minutes. Oh, okay. Well, let me close then with, I'd like to get you to think about what you might do if you were in this clinical encounter. Let's say you're with a patient, a home care visit. As you begin to leave, he says to you, "Nobody cares about you when you're sick. I had friends when I was well, but nobody cares now." So what would you say? You don't want to be coercive. You don't want to, be inappropriate here. So what would you say? Well, I'm collecting data about what nurses would say to this very question. So I thought I would share with you some ideas that they had. Here's what one person wrote. "At least you know who your true friends are. Sometimes the Lord will bless us with situations that help us reveal who is true to us and who is not." So you're chuckling. I hope it's because you're like, "I would never say that." But if you use some of the helping techniques that are in the literature about how you can help this person, I would argue towards Godwardness, towards greater self-awareness, which I personally and professionally see as our goal when it comes to spiritual care. Whoops. You might want to say something like, "Seems like you're feeling maybe, you're all alone. You're not important anymore to your friends." Because what this issue is really bringing out possibly for the patient is they're feeling abandoned, rejected, not valuable, unworthy, something like that. Really a deep spiritual issue. So like I said, oftentimes spiritual issues are very painful and we want to run away from them. But I would argue if you provide a comment like this, you're not coercive, you're not being unethical. Here's another situation. You enter the patient's room. He's in sickle cell crisis. He says, "My pain is so bad. I've been praying that God would ease my pain. He's done it before. I know he can do it again, but it just isn't happening. But I gotta have faith. I know he can take my pain away. I know he can. I know he can." What would you say? Well, I hear a lot of nurses say things like this. "But God doesn't give us more than we can bear." But think instead about possibly a comment like this that might increase their self-awareness and in an incremental way move them towards greater self-understanding of their heart, the divine light within them, or whatever language you want to use here. You might say something like, I hear your determination to have faith. Times like this, I know for me anyway, sometimes can make me rethink my faith. How is it for you? And then allow them, with your nonverbals, an opportunity to talk more and gain self-awareness. Oh dear, sorry. Okay, so to end, should clinicians dabble with patients' spiritual angst? Well, here's a beginning answer. I will say yes, if they have built rapport, respect, relationship first, if they know when to make a referral to the specialist, if they recognize that they too are on a spiritual journey and approach it with mutuality, if they possess some degree of competence, wisdom, and spiritual care, and even better, at providing safe, competent physical care. I've heard and read about how, if you can't get the IV started, or if you bungle the diagnosis and, whatever it is, they're going to lose their trust in you, and you're going to make it more difficult for them when it comes to talking about matters of the heart. Again, observe ethical guidelines. And lastly, I would like to suggest that we should respect the great healer is always at work. Besides, that takes the burden off our shoulder, doesn't it? Any questions? If you want to know more about what I think, the book is coming out in May from the Templeton Press, and in it provides a paradigm about how to approach discourse with patients about spirituality, and then it implements techniques that have been developed in counseling psychology and psychiatry and spiritual direction and moves them into the world of the healthcare professional and provides really concrete ideas about how you can talk with patients at the bedside. Thank you. Any questions? Any questions or comments? Yeah. Oh, okay. If you want to stand at the mic here in the aisle, thank you.
Hello, is this on? I just had a question on the role that, say, an atheist or even an agnostic can play in that. I mean, because many of these studies and still gave the notion that there's an assumptive personal God existing. However, if you don't believe that, or you're not sure, then it seems that there's that significantly can cut it out. But anything to say on that and still possessing spirituality, but not necessarily tying spirituality to a belief in a personal God.
Right. Thank you. Yes, what the literature, what we as healthcare professionals have been doing now for the last couple of decades, we have been kind of removing the language of religion from this discussion, and we've been emphasizing spirituality, and we've been assuming it's a universal. And so when we talk about spirituality, we talk about it in a way that we think also can describe the experience of the atheist and the agnostic, the Wiccan, and so forth. And so, the atheist has a need for meaning, to make sense of challenging health situations. They have a need for hope. They have a need to feel love and relatedness. They have a need to, the list goes on. And so what I think might be also in your question is, well, how can a healthcare professional who is coming from a religious perspective, how can they connect with a person who does not? Was that kind of your question? No? Or just okay. Yeah. Well, I would say, I ascribe to this thinking that spirituality is a universal. I mean, yeah, it's going to get manifest in different ways, in different cultures, and different individuals, and so forth. But we all do have a worldview. We all have assumptive views, and we bring those to the bedside, whether we're a patient or a healthcare professional. So I would say as a healthcare professional, we need to think about, well, how can we connect with that person who does believe differently? What are the fundamental views that we do agree on? And then you can work from there. Does that help? Or it doesn't seem like it does. Do you want to clarify your question for me or go further? No? Okay. Anything else? Yes. If you'd like to come to the mic, thanks.
I really appreciated the quote about how Jesus treated people. I don't believe we should ever dabble in patient spirituality, but all really that we can give a patient who's hurt and dying is what we are and what we have. And if we are people of integrity and faith, we can share what we have and what we are with people without trying to do a deathbed conversion to all of the tenets of our own faith, because that's not the time to do it. And on the second scenario where the man was experiencing, and thank you very much for being here. It's
no problem. Actually, can I clarify your first comment? Did you hear that in the lecture? Did that come through? Because I was agreeing with what I'm saying,
yes,
I think is agreeing.
You did, but I think the dabble part maybe
that needs more work.
Came forth a little bit too much.
Okay.
Not to be critical.
No. Let's talk together. Yeah. Okay.
And I also do not agree with I won't bring that up. The man who was in the midst of the sickle cell crisis in extreme pain and could not bear the pain. I think really the very first thing to do, I think what you mentioned is a wonderful second thing to do. I think the very first thing to do is to see about arranging for a little more dilaudid.
Yes, yeah.
But then I'm a nurse of 30 years.
Yes. Point well taken. But I'd also like to remind you what chaplains have taught me. A lot of times we avoid the spiritual pain by giving the Dilaudid. So you're right. We need to do both.
I'm wondering if you have studied into Nancy Piercy, her book particularly Total Truth.
No, I'm
and its
sorry.
relation to spiritual care. Scholar from Stanford.
Can you spell the last name?
Pearcey.
No, I have to say I'm in the dark there.
Okay. She would have some very interesting perspectives on spiritual care.
Wonderful. Is that book available mainstream press?
Oh, yes.
Yeah?
Mm-hmm.
Okay.
Yeah.
I've just never seen it cited or come
500
across it. I'm
pages,
very
but with
surprised.
50 pages of references, very,
Wow.
very scholarly.
Okay.
And she speaks quite often at many different universities and healthcare institutions.
Boy, I just have never crossed paths.
Nancy
Thank you.
Piercy.
I'll have to go look for it. Okay.
Do you think, Beth, that it matters whether or not the institution that's providing the context for the care is itself faith-based, as opposed to, say, a government institution or one that's a for-profit institution that makes no faith claims? The reason for asking that question is I'm just wondering if should we imagine that the expectations of patients who come to a faith-based institution are different in this regard? Would it be permitted for them to expect more attentiveness to their spiritual well-being by the very fact that they come to an institution that has a religious symbolism associated with it?
Well, you would like to think that a faith-based institution with its mission statement, et cetera, would filter down and make a difference at the bedside. I think also it's possible that sometimes these institutions can use that difference to sell themselves, and should sell themselves that way. I've seen billboards advertising, well, healthcare at this hospital, nurtures the soul as well as the body. You could really use that for economic reasons. But the reality is we're in a society right now that is expecting actually all health institutions to address this. So I don't know how much difference you do actually see at the bedside. And also, the reality is, at least in nursing, the kind of people who are attracted to nursing are often religious people, actually, or people with a lot of high self-reported spirituality. And that inevitably, data shows that inevitably goes to the bedside. So, if you've got an equal number of religious people or high self-report spirituality clinicians you've got equal numbers at these institutions, then you would think maybe care would actually be the same. I don't know. I did an in-service a month or so ago at the VA here, and they were very desperate for this kind of information because they're feeling the pinch from JCO. They didn't have in-servicing on this, and so they, please come and help us. So, yeah.
Just a comment, I'm not a healthcare professional, but I have volunteered for several years at a local community hospital as a pastoral care visitor, and I was very impressed with the practicality of what you said today and the accuracy with which you described the kinds of questions that are asked and the kinds of lack of meshing of my type of person. I've talked to pagans and Jews and Muslims, and it is difficult. You described it very accurately. I thought it was most helpful. Thank you.
Well, thanks for the affirmation. I'll keep going then. Okay.
Thank you, Professor Beth Johnston Taylor. Look for our announcements for the next session, which I think will occur in January, and thank you all for coming today.